So now that osimertinib has moved frontline, we have to figure out what we do after resistance to osimertinib develops. So there was just data presented at ESMO this year by Dr. Ramalingam at Emory University, which started to examine this specific question. And there are basically two dominant mechanisms that emerge. One is acquired EGFR mutations, so the most common being C797S, which prevents binding of osimertinib. And then you have amplification of genes, of which MET is the most dominant. The issue, though, is with the mechanisms of resistance to first-line osimertinib, they're much more heterogeneous than what we saw with progression and resistance on first and second generation EGFR TKIs, where 60% had a T790M resistance develop. We don't see that kind of dominant mechanism of resistance, which complicates things. And in addition, oftentimes these resistance mutations that we do see are often co-occurring, so it becomes very complex. So right now, after a patient progresses on frontline osimertinib, we have to rely on platinum doublet chemotherapy thereafter. But there are many clinical trials looking at several combination strategies targeting some of these resistance mechanisms that have been discovered.